Good morning, everybody. Can I just not hear? So I'll call this session of the study committee to order. We are missing some legislators. Representative Bennett is running late, and I think we have a couple of other conflicts, but the really important people are here, and I thank the members of my committee that are in attendance. So I'd like for us to get started. Today we're going to try to keep on schedule a little bit better. Leo is going to be a timer. Has nothing to do with the presenters today. It's just that the bureaucrats that came last time from our own departments seemed to quite long-winded, and I guess it was their time to shine with what they wanted to say to us, and we ran pretty late. But we have a field trip once this committee meeting is over, and I would like to see us on the bus and ready to go at 12. So we will be keeping people to a time schedule. You'll notice that the topics today all relate to HIV. When we started deciding what we would have the study committee, it was one of our main focuses because so much has changed in the last few years regarding HIV and the treatment, and I thought it was a good idea to bring our committee up to speed on that and to look and see if there are places that we need to change our approach or to certain areas relating to HIV. So with that, we're going to get started, and let's see. Okay, we'll start with Dr. Wendy Armstrong. So Dr. Armstrong, if you'd like to introduce yourself, tell us where you work.
I will do that. Let me just get my slides up here. So I'm Wendy Armstrong. I'm a professor of medicine at Emory University and the medical director of the infectious disease program at Grady Health System, which is the largest clinic in the state of Georgia and one of the top 2 or 3 or 4 largest clinics in the country caring for HIV patients. So we see about 6,000 patients. I'm also the immediate past chair of the HIV Medicine Association, which is the national association that represents HIV providers. So you can see the title here. I've been tasked to give you an HIV 101 in 2017. So I'm going to try and do that. You can see that the title is, it's mostly not 1981 anymore, thank goodness. We still see pockets of trouble and unfortunately individuals who come to care late. But in general, this is a changed disease, and I want to tell you about that. These are the images, I think, that you guys remember from the early days. I think most of us here are old enough to remember Rock Hudson and Ryan White and the movies and so on. But what I want to tell you about now are current outcomes, the state of HIV in Atlanta in 2017. I want to talk about how HIV is transmitted and what we can do to prevent that and how ultimately we control this epidemic, because Atlanta and Georgia have a problem. So the first slide here just gives you the general classic course of untreated HIV infection. And so in the blue squares is a measure of the immune system, what we call the CD4 count. And you can see that once infected, and that's at the left-hand side of the graph, over time the immune system diminishes so that that blue line goes down. And at the same time that the immune system declines, in red is the amount of virus, and the amount of virus initially very high at the time of first infection, and this is important, just like when you get a cold, an upper respiratory infection, or the flu, initially virus goes crazy in our systems. Our immune systems control that. The same thing happens in HIV, so you see that the red line goes up, it comes back down. But unfortunately, the immune system in HIV is unable to get rid of it the way we get rid of the flu virus. And so it remains in the body and then slowly increases in amount over time. And so that's untreated HIV infection. And as the immune system declines, and that's depicted in the curve there, all the words are opportunistic infections, or infections that a normal person with a normal immune system would not be at risk for. As that immune system declines, individuals get infections that can be fatal, and that is when we call someone as having AIDS, or later stage disease. Well, antiretroviral therapy has been a miracle, frankly. It has been one of the most impressive discoveries in modern science, is how we understand this virus and how we've learned to control it. And here, what I'm showing you is the survival gains, and this is 10-year-old data. Things are much better even now. But if you look at the right, that's the number of months of survival gain using antiretroviral therapy compared to things that we think of as common. So in the other bars, and I realize that slide is very far away, are things like chemotherapy, state-of-the-art care after a heart attack, bone marrow transplantation for leukemia and lymphoma. And you can see that all of the benefits from those kinds of interventions are dwarfed by what we can do with antiretroviral therapy. Again, this is very small, but now in 2007, people looked at how many additional years of life expectancy someone treated with HIV could expect. And so they looked at somebody that was 20 years old and said, how many more years of life could they live? And in the red on the right is what I've shown you are the answers. And for someone who is actually in care and doesn't have other situations, like men who have sex with men, the life expectancy is 77 years. So that's a normal lifespan in someone with HIV. You can see that for IV drug users, that life expectancy is about 50 years old. That's not so much the HIV, that's the issues with IV drug use and the other conditions. And you can see that this highlights two other problems. One is that non-whites, the life expectancy is 58 years versus 72 for whites with HIV. That's a marker of the really terrible healthcare disparities that continue to exist in our society. And that those who find out about their HIV later with lower immune systems to begin with have a shorter lifespan than those who find out earlier. But HIV-infected patients are living longer, and as this graph shows, this is the proportion of patients who live to be greater than 50 years old. And in 2017, the proportion of patients who are greater than 50 years old, and in 2017, 50% of our citizens living with HIV in the US are 50 years or older, and so people are living longer with HIV. So that's great news, and it isn't surprising then that there has been a global decline in new HIV infections. So you can see on the top new infections going down and deaths from AIDS going down globally. Well, what about in the US? We have pockets that are still trouble, and pockets where we are still seeing new infections and bad outcomes. And these pies that you can't see, but I'm going to show you, illustrate where in the US the epidemic is concentrated. So 45% of the epidemic is in blacks or African Americans. That's disproportionate to the amount of the population that blacks and African Americans make up. 65% in men who have sex with men. 51% in our youth, less than 35 years of age. So this is shifting again to be a younger epidemic. And 51% in the South. And really shown very starkly, you can see here that the number of new HIV diagnoses by region in the South in 2014 completely dwarfs the other areas of the country. And so here we have a problem. And if I haven't convinced you, I'm going to beat that into you in the next 3 slides. These show new HIV infections in the US, and Georgia is number 2 among states. That's not where we want to be. And number 3 among states with the rate of AIDS or late stage disease. And so that's Georgia. Now, if you look within Georgia, you can see that's a map of Georgia, and dark is bad. And you can see that there are actually areas throughout the state. So many of our cities, many of our rural regions have bad epidemics. Certainly Fulton County is bright purple here as well as an area of considerable problem. And here shown even bigger again. You can see that this is an epidemic scattered throughout the state, but certainly very active here in Atlanta. Here is Atlanta, and Atlanta is the metropolitan area in the country with the 7th highest rate of new diagnoses. So we have an issue. Who's at risk of HIV infection in the US? I showed you some of those stats, but to me, this is a stat that continues to appall me. And it is the CDC estimate that African American men who have sex with men have a 1 in 2 or a 50% lifetime risk of contracting HIV. That's all comers. Any African American man who has sex with men. That's a problem, and it's not because our African Americans engage in more risky behavior than white men who have sex with men, and it's not a behavioral thing. It is because we have so much HIV in that community that if you have one partner, the likelihood is that that person is infected as well, much greater than if you're a white man who has sex with men and has one partner. And so the risk is great, and we need to get our population into care and treated, and I'm going to show you more about that in a minute. Lastly, and this is my last slide to enforce what a problem we have in the South, you can see here that the rate for everyone in Georgia is 1 in 50 people have HIV. So that's number 2 among states, number 3 if you include the District in Columbia. 1 in 50 people in 2017. That just seems like that should have been a time that passed a long time ago. And why is that? You can see that the South was the problem there, and so partly location, but it's really that the epidemic has shifted into a more vulnerable population. Our youth, individuals in poverty, we have significant challenges with stigma, with homophobia, with less access to health insurance. And so we need to start treating our way out of this disease, and that's what I want to talk to you about next. So as we talk about HIV transmission, there are really three and only three ways that one can contract HIV, and you guys probably know this well. The first are blood and blood products, and certainly early in the epidemic, transfusions were a risk. It's extremely, extremely rare to get HIV from a transfusion these days because of better screening techniques. The second, of course, is sexual contact, and that can be a variety of different types of sexual contact. And last is vertical transmission, so from mother to child, either through the birth process or breastfeeding. Now, what does not transmit HIV? I think it is actually really important to know that other activities don't transmit HIV, including saliva is not a body fluid that has HIV, so you cannot get HIV from biting or spitting. Urine, feces, vomit, sweat, tears, etc. These are not ways to get HIV. It really is limited to those three things that I told you about earlier. When we think about what is the risk of transmission, and you've got that in front of you on the handout, so I'm not going to read through all these, but the risk may be lower than you expected. Now, these are estimates, and this is all folks without other mitigating circumstances, and I'm going to tell you about the mitigating circumstances. But if I were to have a needle stick from an HIV-infected needle, my risk could be about 1 in 300, a splash in the eye about 1 in 1,000. If I were using intravenous drugs and had an intravenous needle, it would be 1 in about 150. And then you can see the sexual transmission with receptive anal intercourse being one of the highest risks of about 1.4% or 1 in about 70, and so on. Now, just to give you a comparison, we know what the risk is with a needle stick from other things. So it's a way to give a same comparison. So HIV is about 3 in 1,000 in that way. Hepatitis C virus is about 3 in 100, so it's a much higher risk. Hepatitis B virus is about 3 in 10, so a much, much higher risk. When you look at other sexually transmitted diseases, in syphilis, your risk if your partner is infected is about 60%. If your female partner has gonorrhea, the risk of transmitting to a male is about 20%. And so you can see that it is actually a small risk, but certainly present compared to sort of other kinds of things that we think about. But the key is that these are average risks of HIV transmission, and individual risk can be influenced by a number of different factors. And so I'm not going to read through all of this, but there are different things that modulate the risk. So one very, very critical, and what we'll spend time on, is how much virus is in the bloodstream of the individual who might be transmitting HIV, or how much virus is in the genital tract, and so on. And this relates to the timing during their infection with HIV, and we'll talk about that. But other things like having concurrent sexually transmitted infections are really important because, again, if you have an ulcer, that gives an opportunity for more exposure through a sexual act that may, again, lead to transmission. In the recipient, a lack of circumcision, for example, increases your risk of transmission, and condoms obviously decrease risk. So what are the times of greatest risk during the course of HIV infection? And here's that same graph I showed you earlier. Blue is the immune system, red is the amount of virus, and there's 2 times of really significant risk. And the first is during what we call acute HIV, right after somebody gets the virus, when I told you that the virus goes crazy in the body like influenza and so on. And unfortunately, that's a time when most folks are unaware that they're infected. They often don't have symptoms or have symptoms that may be written off to a cold. And routine testing would be negative often in those settings. And so that's a time of risk, but it's very, very hard to be aware of and to prevent. And then the second time is, of course, an untreated disease, later in disease when virus again goes up in the system, in the body. So what about treatment? And that's the key, and that is what has changed in 2017. And so here in a nutshell is HIV. I showed you that virus goes way up and then it comes down to a level and then it sits there for a while and increases over time. But when we treat someone, here's what happens to virus. Virus becomes what we call undetectable, or lower than we can detect with our usual blood tests and our standard assays in the laboratory. And so that means that the amount of virus in the blood is usually less than 40 copies of virus per cc of blood. And that's actually a really important measure, because at that moment, it becomes extremely difficult for that person to transmit HIV. And we know that in part because of this study. This was a study that was published in 2011 that followed couples where one person was infected and one person wasn't. And if the infected person was treated, the risk of transmission to their partner was really zero, as long as they'd been on meds for about a month of time. And this was such an important study that changed worldwide policy that it was named actually the breakthrough of the year by the preeminent journal in the scientific world. And this has led to a campaign that you may have heard of called U equals U, undetectable equals untransmittable. And it has been an important slogan and an important campaign to talking about stigma and talking about the importance of becoming undetectable with respect to your virus. And virtually every important group has signed on to the undetectable equals untransmittable, the U equals U campaign. And you can see here that again, these are many important groups in the HIV world, but perhaps most importantly, about a week ago, the CDC joined the consensus statement on HIV that undetectable was indeed untransmittable. And so that's actually an incredibly important message for us to get out, not only because of the science of HIV and understanding what risk is, but also around policy and everything else. And it really is a game changer. Just to sort of show you in another way how solid this data is, this is a study that was published last year looking at sexual activity without condoms in couples where one person's infected and one person wasn't. The study followed 1,166 couples. About 2/3 of those were heterosexual couples, about 1/3 of those were men who have sex with men. And in each case, the infected partner was on medication and undetectable. They tracked sex acts, and there were about 58,000 reported sex acts over 4 years in this group, and there were 0 cases of transmission, 0. No condom use, only medications in the infected partner, 0 cases of transmission. So 58,000, that's a pretty good number. And this, 10 years ago, the Swiss understood this, and their national statement says that they propose that the risk of acquiring HIV is negligible from an HIV-positive sexual partner with an undetectable viral load amount of virus. And they suggest that people can stop using condoms if both in the couple are agreeable. So even national Swiss policy was no longer to recommend condom use in individuals where the infected partner was treated. But we still do have transmission, and so the question is, when does transmission occur? And there are this is a study that was done by the CDC, actually using many sites around the country, but including our clinic. And they found that really there are 2 major times that transmission occurs. About 1/3 of transmission occurs in that group that is HIV infected but not yet diagnosed, so they don't know they're infected. So how do we fix that? We must facilitate testing, which requires education. It requires decreasing stigma. People are afraid to get tested because then it puts the rubber, the red H on their chest for the rest of their life. And it requires linking people to care, making sure that if we test them, we figure out where they can get care and become undetectable. And then the second big group are people who are diagnosed but are unable to be retained in medical care. And that's a really complicated group and one we really struggle to understand how best to serve, and I'll tell you a little bit about that. But the key is that as HIV has moved into a more vulnerable population, there are a lot of social issues and other kinds of issues that affect their ability to get in care. And that can be transportation to the clinic. That can be stigma. I can't tell you how many of my patients say, I don't want to walk in your door because if somebody sees me, that outs me. That can just be not having enough money for a copay for a month. And so we have to reduce barriers to care and assure continuous access. The key for us is continuous access to medications because those in care have 0 transmission, and that's how we treat our way out of this epidemic. The other thing, so one is, so we want to promote testing, and it should be that everybody should know their status and not feel uncomfortable with that notion. New York has led the way here by setting up sexual health clinics set up by their Department of Public Health. And their sexual health clinics, again, don't have a lot of stigma. And you walk in, and if your HIV test is negative, fantastic. But then you get coupled into prevention intervention. And I'm going to talk about PrEP in a second. If your HIV test is positive, you're immediately shuffled into therapy. And it's a way, again, to really destigmatize things and get folks what they need to maintain their sexual health. So we have a number of prevention tools. Obviously, treatment is one. Vaccines are a very, very long way off. Circumcision is used widely in Africa, but it's already widely practiced in the US. Topical kinds of agents like gels and so on are not commercially available. And so certainly condoms, but that's a behavioral intervention and it requires behavioral use. But one very important one is pre-exposure prophylaxis. And you may have heard about this, the pill that you can take to prevent HIV. So this medicine, Truvada, was approved in 2010 for prevention of HIV infection. And people liken it here, instead of having the condom to having the pill. It can be extremely effective when taken. And so here are, there's evidence for preventing sexual HIV transmission. The number one thing we can do is the top line there, 96% prevention with immediate therapy for a positive partner. But the next 4 lines down there are a variety of studies looking at the effectiveness of pre-exposure prophylaxis. And in those groups, the numbers vary, but in those who were adherent with PrEP, there was 90% protection. And so the trick is figuring out how to help people become adherent to PrEP because it works very, very well. So that's prevention. What about now keeping people in care? And there are many barriers to continuous care because, again, our key is continuous care. And that includes access to medications. Many of our medicines or most of our medicines are on the highest tier for insurance companies that are subject to high copays. Our medications are not necessarily protected classes through Medicaid and everything else. We have many options that are single tablet regimens where there can be multiple medicines in a single pill that promotes adherence. It's a lot easier if you don't have to go pick up 3 different things with 3 different copays at the pharmacy. If the pharmacy's not out one day, if you can take 1 pill quickly in the morning. But oftentimes we have to undergo prior authorization to get these single tablet regimens, or they're not preferred on formularies. So access to medicines is key. Decreasing stigma is key. Talking about this, normalizing this in our society, saying that we know that this is out there and it's not something to hide under the carpet, but it's something to talk about. Helping with transportation. Transportation is one of the #1 issues for my patients. We have incredible bureaucracy to access health care. So for the free health care that we can offer through the Ryan White Care Act, that requires a patient to go get, for example, a wage and labor statement from the Department of Labor. To get that statement, first of all, they got to be healthy enough and have transportation to go there. Secondly, they have to go in with a photo ID. But a photo ID requires a birth certificate. And a lot of our patients, that's a huge hurdle to go through. And so the number of stops and the number of places that people can become derailed and say, I just can't do this, or the health system doesn't care about me, or if you've just been in the hospital with meningitis, it's really hard to undergo these steps. So we put a lot of bureaucracy in place. And then what we know works are things like patient navigators to help get through these steps and these stages, or to help people get to clinic. And we use them all the time. We've got great data in breast cancer that showed that it changed the outcomes in breast cancer. Great data in getting people to colonoscopy by patient navigators. But in our environment, again, with vulnerable patients, there's not a lot of money for us to hire patient navigators, and often insurance and so on aren't issues. And so we need more patient navigators, more outreach, more reaching people in the communities where they live, rather than having them always come in. And so to sort of, okay, I'm almost done. So I just want to introduce then and show you this notion of the care continuum. And so this is a graphic way, and Dr. Wortley's going to present more on this, to show that how are we doing? Well, we diagnose about 80% of our patients. Only about 60% are linked to care. Only about 40% are continuously retained in care. And if you get to that point in general, and this is slightly old data, people, if they are retained in care, usually easily achieve viral suppression. And this works. And I'm going to skip this Vancouver data and show you San Francisco data, but communities that have really worked hard to get care to all of their patients have been able to reduce, in the red line there, new HIV infections, reduce the amount of virus in the community, and reduce HIV incidence. And that's what we need to do in Atlanta. So my last 2 slides, since I'm on time, are key learning points. One is that all transmission requires a discordant relationship, 2 people. And so there's 2 people in every relationship, and both people need to take responsibility. The efficiency of transmission is affected by factors that change the infectiousness and susceptibility, like viral load. But antiviral therapy reduces transmission enormously. It's the most effective thing we have for the infected patient. But the most important thing that we can do is provide an environment which encourages personal responsibility for sexual health, reduces stigma, and encourages and facilitates testing, linkage, and retention in care. And so, again, this is our challenge in Atlanta. I'm thrilled that you guys are interested in hearing about this. I want to call out Representative Price for the support for syringe exchange programs, certainly as well, which is another important component to this. And implore you to think about how we can use policy to help us help our citizens. And so thank you.
Very much for being very succinct. I gave you a little wiggle room, and I'll do that for everybody. And I think we're going to have quite a few questions. Dr. Felzine.
Dr. Armstrong, it was a wonderful presentation. Thank you for coming and presenting today. I have several comments, and I have
As I say, you know this all well. I know you do.
been seeing HIV since 1992, and one question that comes up all the time is, if not now, when? So I think the when is now, and you need to push forward. And I like your comment, especially that you mentioned the state of Georgia, not just the state of Atlanta. So I do appreciate that, and really your comments on stigma and mixed messaging also. People around the state and around the country are getting messages from home, from church, from work, from media, which is also a huge challenge. I want to add a couple of things. Because of the new data that came out with the CDC, your comments on condoms, just so everyone's aware that we have to be very cognizant and cautious in making those comments, because I'll have clients that will hear that. And to keep in mind, the CDC just released its data. We are now number 3 in gonorrhea. We are number 2 in syphilis. We're number 6 in chlamydia. So we have very, very high recoveries in STDs. So keep promoting prevention there from that standpoint.
Absolutely.
So we do want to keep that in mind when we're thinking about those issues. One other issue that I think is so important that I just want to comment, because your data was fantastic, is the CDC just released data as number of cases. We are number 6 for mother to child transmissions, which is appalling.
Yes.
So that just adds to, if not now, when are we going to do this? So that leads to a couple of things. I do want to make comments that there is no data that an STR is superior to once a day, but I wholeheartedly agree in your comment that getting approval through PAPs for 3 drugs is much more challenging than 1 drug in getting that. So I wholeheartedly agree with that. I just want to make that comment. So 2 things. 1, workforce capacity. So we can have all the meds in the world, but workforce capacity, we are in a state of emergency in this state. So across the state, we have high turnover rates. We have issues of only about 50% of our providers in rural Georgia are ID trained. About 20% are certified through the American Academy of HIV Medicine. So that is something that is an issue. When I'm interviewing nurses who trained in Georgia, and I asked them about their HIV experience. Oh yeah, I think I took care of somebody with HIV with DKA when I was on a hospital rotation. That's their experience.
Right.
That is appalling. So we need better education, and as in your position, and I'm sure you're talking to universities across the state. So my first question, and then I'll get to my second, and then I'll get off my high horse, is what are the universities doing to train? What are universities doing to get information across there? Is Emory and Grady looking at expanding telemedicine, looking at platforms like ECHO, like I've mentioned in the past, to try to improve the community so we have better care for our clients across the state? That's one question that I would love to hear your answer. Your second is just on your point when you're talking about bureaucracy, and my expertise, of course, is in Ryan White centers. You do not have to prove that you're an American citizen to get Ryan White services. So there isn't that type of barrier. Now, there's other barriers that you mentioned, transportation, there's stigma, there's all these type of things. But is that an issue more of in the urban centers? Is that a Part A issue? Because since I work mostly with Part B, C, and D, and you're more of the Part A expert in the room, that would be my second question. So number 1, workforce. Number 2, what is the issue that we're seeing with bureaucracy?
So workforce is a huge issue, and it's a national crisis. There has been data that shows that in 5 years we will be short the capacity to care for more than 50,000 patients. There are fewer people going into infectious disease. Infectious disease certainly doesn't have a lock on people who can care for HIV. We need to do more education and treatment. Education about treatment. One of the things we've been advocating for example, one of the issues is pay, and that's a challenge for our nursing, our physician assistants, as well as for our physicians, Ryan White clinics, and so on. It's hard to sometimes take public health jobs with the amount of medical school debt, et cetera, as you know. One of the things, for example, that we're advocating for is to have Ryan White clinics or clinics that care for underserved patients with HIV count towards the National Health Service Corps. So that would be with a loan payback sort of scenario that exists for primary care for OBGYN, but not for people who are giving primary care to this vulnerable population. It's a huge challenge, and telemedicine, we have definitely talked about that, but it helps with getting to rural outreach, but it doesn't help with workforce because it still takes the doctor the same amount of time. And so that's been one of our barriers, is that we're just trying to struggle to have enough workforce to treat the folks that are actually present in the building, but absolutely telemedicine is a way of the future and so important that we develop better networks for our rural communities. And then the third thing is that we need to, I think, advocate for maintaining funding. In one of the proposed budgets, the president's proposed budget suggested cutting the AIDS Education Treatment Centers, the AETCs, as part of Ryan White funding. And that's actually a mechanism that trains folks who are through their medical training but don't have training in HIV, how to care for individuals in rural communities or in any community. And so that those AIDS education training centers, I think, are an important outlet. We have a problem, and and there's no easy fixes for how do we have enough workforce capacity. So I don't know if that answers that part of the question.
Chair, thank you. Thank you for the extra time. So I just want to plant this seed because I know you're also intimately involved with the Ryan White Coalition, National Coalition, and I've planted this seed, and you've heard me before, but I want to say this publicly, that with workforce capacity the way it is, we're missing a huge opportunity in not allowing individuals with J1 visas to be able to participate and work in Ryan White clinics.
Yes.
So I want to throw that out there, but I'm wholeheartedly excited about your comment about adding this to the service corps, because we've got to do it. And I know we've worked with this corps before, and one of the challenges I want to throw out there is we were about to hire somebody in Douglas, Georgia. And you would think Douglas is an underserved area, and it is if you're from Douglas, Georgia, but they decided to bring in specialists, like one day every 3 months, one day every 6 months. And because they did that, the Corps said they're no longer underserved. And that is an atrocity that we need to think about and overcome.
Yeah, so I'll quickly answer. You're right that you don't need to be a U.S. citizen to access Ryan White care, and that's a separate pathway. But if you are a U.S. citizen, then you do need to actually have a photo ID to get the wage and labor statement. You don't need to get it to get into Ryan White, but you need to get to the AIDS Drug Assistance Program. You need to have a wage and labor statement proving your wages if you don't have a job and don't have pay stubs. And similarly, so it's a strange catch-22 where Ryan White doesn't technically require a photo ID, but if you're going to get the statements that they do require, you do have to have it. Those rules are waived if you're not a citizen.
We're talking about federal law.
We're talking about guidance from HRSA.
Federal.
Yeah.
Okay, so it's not something that we have the ability to change. Federal.
No, I know. I think that's a good question, and the question is, how much could we in Georgia create some alternative, some expanded criteria? And I think that HRSA would be willing, if you had a mechanism to try and certify wage. I think they would accept lots of answers because they have become more and more flexible. So it's really our Department of Labor that requires that you stand there in person with a photo ID to get that statement, for example. So I think it's a mix between, HRSA requires a wage verification in some way, but how we implement that is more of a local issue.
Okay, if you want to get that to me and a possible suggestion for changing it specifically, we'll look at it. Dr. Graham.
Hi, Dr. Armstrong. Thank you. Great presentation. I just had a quick question about PrEP. Is there a recommended target population for PrEP, or will it become as prevalent as all of the other kind of vaccinations or recommendations for kids at certain ages? And my second question is is it covered by Medicaid or Medicare or any other insurance companies? Is it typically on the formulary and available?
So first question is who is eligible for PrEP? And yes, we could sprinkle it in all the water, but it is high for higher risk individuals. And there are suggested guidances from CDC about how many sexual partners and so on that is. I would argue that if you are, for example, an African American black man who has sex with men, that your risk is 1 and 2 and you need PrEP. The challenge is that our uptake is high among folks who are in care, and one person has HIV and one person doesn't, and they, where their risk of transmission is virtually zero, and they're a highly educated population. But getting this to our youth and getting this to our more vulnerable populations has been really, really, really hard. And so getting that message out is really key. But that's certainly the higher yield target population. We need to understand more about women with PrEP too, and that's an area where there's not a lot of good research.
And if you're in that high-risk population, would it typically be funded by insurance companies?
So if we can, PrEP clinics, it is covered by insurance, and the company that makes the pill has actually a great patient assistance program that requires some paperwork, but it's not insurmountable. And so we can usually get the drug. We need to have sort of the clinic where we can draw the few labs that are necessary to do this safely. And we need to get people, so we need a place for people to go that doesn't feel stigmatized, where support for the physician seeing them and some lab work, and we can get the drug, which is the most expensive part of the cost. So, does that answer your question?
Yeah, it does. Thanks.
Are you saying that our public health departments don't have that stigma for patients?
Our public health department has opened a PrEP clinic, and they have done an absolutely fantastic job. But it is still, and with David Holland's leadership, they are really trying to convert to this positive messaging of sexual health in Fulton County. I don't know how pervasive that is across the state. I'm not sure that it is, or that there are PrEP clinics across the state. And so I think that overall we need to change messaging more than just in one site in Fulton County that has a limited capacity.
Okay, but it sounds like if they can do it in Fulton County, they might be able to mirror that in other public health
Yes.
departments across the state, if that was something they took on. Okay. Dr. Feldine?
If you could also get me that information that you're going to be sending to Madam Chair. I will just mention that Dalton has a PrEP clinic, Macon has a PrEP clinic.
Oh, great.
So
In public health?
and Athens has
public health.
no. Because, well, yes, Dalton is in public health, Macon is in public health, Athens is through Piedmont with the assistance of public health. Because keeping in mind that Ryan White dollars cannot be used for prevention and cannot be used to pay for these medications. But saying that, I will say that the state of Georgia is looking at policies and looking at trying to overcome that barrier, and hopefully that will be available to everybody in the coming. But you can follow on www.gacapus.com. We continue to try to update that website for PrEP clinics across the state. So definitely, I know they're seeing patients and prescribing PrEP, Athens, Dalton, and Macon.
That's great.
I had a couple of questions. In our young population, would the problem be that they're growing up not seeing people die, and now it's seen as a disease that you can live with? It's like diabetes?
Yeah, so it's a combination of things. So that's certainly been out there. They are not growing up in the early 80s. So there's no question about that. But there's also no question that there isn't enough education to that community as well. And so as often as not, I have patients who are really unaware that their risk is high in the 2017, because not only are people not obviously dying from that, although I'll tell you people die at Grady every week, but we don't talk about HIV anymore. So people don't realize that it's 1 in 2 individuals in the community that can, 1 in 50 Georgians have HIV. So they don't realize that there's a risk. And so it's more than just it doesn't matter if I get it. I see that very, very infrequently. It's much more gosh, I really didn't understand that. And then their adolescence.
And I would take it that that the adherence to medication when it's multiple pills would be the same as diabetics, who don't adhere to their medication because over a long period of time it just gets to be an awful routine to have to take shots or pills and check your blood sugar and so forth. So they would be the same way with taking multiple pills.
Yeah,
It's just
so
the kind of-
there's no question, medication fatigue, for sure, is a challenge. But I'll tell you, more often than not, my people who fall out of care, certainly there are some that say, I just stare at that bottle every morning and I just can't bring myself to open it. But more often than not, what leads people to fall out of care is, my grandmother died and I had to go to South Carolina for, a month to help the family and I missed my appointment and I came back, or my car broke down and it gets somebody out of the system, and then there's not an active way to wrap them back in the system.
Okay. And I just lost my train of thought. I was going to ask something about. I lost my train of thought. Okay, are there any other questions? Thank you very much.
Thank
we may
you.
have questions. Are you staying in case there's questions later?
I'm
If
going to
not,
have to
it's
scoot
okay.
off in a little bit.
That's
Not
fine.
right away.
I'm sure we'll have somebody that can answer them. Thank you very much
Thank you.
for taking your time and for the information and for sending me the other information that I asked for. Thank you very much. Let's see. Okay, next we have Dr. Pascal Wortley.
Good morning.
Pardon? Good morning. Did I pronounce it? And right before you get started, let me ask a question. We were having a visiting physician with us, and I don't know whether we've missed connections with him or not, but Dr. DaCosta, you're here. I think I probably have an aide still standing down on the street. Dr. DaCosta is from Brazil, a dermatologist, and we're very glad to have you. Thank you. I'll tell John he can come back upstairs. Somebody can get a hold. Oh, he's here? Okay. I'm glad we didn't lose you. So thank you. Okay, Dr. Wortley.
Good morning. Thank you for having me here this morning. I'm the director of the HIV Epidemiology section at Georgia Department of Health, and we conduct HIV surveillance for the state of Georgia. And I'm going to give you a bit of a whirlwind tour. My mission was to focus on the HIV Care Continuum, and I'll do that. I'll start off with a few comments about diagnoses of HIV in Georgia, and at the end I'd like to talk a little bit about HIV among injection drug users. So as you heard from Dr. Armstrong, we are high up there in the rankings in Georgia. For number of persons living with HIV, we're fourth in the country. And as far as new diagnoses, we're second as of 2015. And I listed it out this way just to see that to show you there are 4 states clumped up there at the top: Louisiana, Georgia, Florida, and Maryland. And then there's a pretty big gap until we have the next set of states. So as you heard before, HIV is increasingly concentrated in the Southeast. This graph shows our new diagnoses over time in Georgia for men and for women. A slight decline over time. I wouldn't pay too much attention to that uptick in 2015. That's partly a surveillance artifact. It'll come down over time as we deduplicate across states. But it's not declining as much as we would like to see, of course. I wanted to talk a little bit about geographic distribution to build some more upon what Dr. Armstrong discussed. So this shows rates in men by district and by sex. And so the highest bar for men is in Atlanta. To a large extent, that reflects the fact that there is a higher proportion of men who have sex with men in Atlanta compared to outside of metro areas. But then when you look across the state, you'll see that aside from Atlanta, rates tend to be higher in the southern districts than in the northern districts. And that's true for African Americans. It's true for Hispanics as well. It doesn't vary quite as much for whites. And now this is a similar graph for women. Again, I should have described for African American women are showed in dark green, Hispanic women in a lighter green that doesn't show up that well, and white women in light blue. And we see the same pattern with higher rates in the southern districts of the state: Albany, Valdosta, Waycross. I'd be remiss if I didn't say anything about perinatal transmission. As mentioned, I think, by Dr. Falzine, we're 6th in the country. This shows our number of cases by year. In blue are cases where mom resided in Metro Atlanta, in yellow outside of Metro Atlanta, so it's important to recognize that this happens all over the state. And to put this in perspective, the entire state of New York achieved 0 perinatal transmissions in 2014. And there are twice as many women living with HIV in the state of New York as we have here in Georgia. So there's clearly a fair bit of work to do there. And some of our ongoing causes, when we look at what resulted in this transmission, are women who may have already been diagnosed before pregnancy, but they didn't receive any HIV care during pregnancy. Women who were not yet diagnosed and didn't get any prenatal care, so they didn't get diagnosed during pregnancy. And then also women who were infected during pregnancy. Recently, we've actually, as a result of third trimester testing, caught some in the third trimester, but unfortunately transmission wasn't averted. And then before that, we've had transmissions that weren't identified until later. All right, now this is the meat of what I was asked to talk with you about. So the HIV Care Continuum that Dr. Armstrong described briefly. So I just want you to understand that in HIV surveillance, we receive all laboratory reports. Labs are mandated to report to us, and that includes the diagnostic labs and also the ongoing care labs, the CD4 counts and viral loads that were discussed before. So what that does is that we can tell if people are in care or not, because if we have somebody in our system, but they're not getting those CD4 counts and viral loads, well, that means that they're not in care. So what we do is we describe people and we break them down into several categories. We look to see if somebody had, over the course of a 12-month period, any care. Did they get any HIV-related lab? So what we see is that about 2/3 of people had some kind of HIV care. About half, 49%, are what we consider retained in care. They had 2 labs at least 3 months apart. The recommendation is that people be seen every 6 months, more or less. So that's about half of people living in Georgia with diagnosed HIV were seen regularly over the course of a year. And about half were virally suppressed. I do want to mention, because you might wonder, why are there more suppressed people than retained people? Some people actually come in only once a year because they're long-term, well-established patients, and they just come in once a year and they're doing well. So those are separate bars. And then finally, we like to look at people who are in regular care and how well are they suppressed. And as Dr. Armstrong said before, they tend to do well. 85% approximately are suppressed. We also look at linkage to care, so that's for newly diagnosed people. How quickly do they get into care? Up until last year, we looked at care, getting into care within 3 months of diagnosis. Nationally, that metric was changed to within 1 month because, of course, people really should be getting into care sooner than 3 months. If we're diagnosed with anything else, nobody says, well, why don't you come back in 3 months? So there was no reason to treat HIV differently. So our measure, we used to have, under the old measure, about 82% of people linked to care based on having some kind of HIV-related lab within 3 months. Now the bar is higher, and we have a ways to progress. So we're at about 2/3 of people come in within a month. So our goal is to get 90% of people in within a month. So I wanted to talk a little bit about disparities that we see in the HIV care continuum. These are data for Georgia as a whole for 2016. And here I'm focusing on racial ethnic disparities. The dark blue line is African Americans, the middle blue Hispanics, and the lighter blue whites. And among people with any care, Hispanics were a little lower than blacks and whites. Similar percent retained across groups, but I want to focus on the bottom line, what we really care about, which is what percent of people were virally suppressed. And here we see overall that blacks and Hispanics were less likely to be virally suppressed than whites. So that's that third clump of bars. And then when we focus on people who are in care, people who had at least 2 visits, we again see a disparity. So these are people who are showing up at the clinic at least twice a year, but we're seeing differences between groups. These are patterns that are actually seen generally throughout the country. This is not just in Georgia. Another important disparity is the disparity by age. And again, the farthest clump to the left is people getting any care, which doesn't really vary much by age group. You probably can't see that very well, but these are 10-year age groups, starting with the youngest group, 13 to 19, and moving up to 55 plus. What you can see from where you are is that there's a relationship with age. So as people get older, they're more likely to be virally suppressed. Younger people have a harder time staying in care. And interestingly, even when they are in care, the last group to the right, they're less likely to be suppressed. So even though they're coming in for visits, they're less likely to be achieving suppression. And so, well, it's probably adherence, right. And there's why it is that the adherence is less is complicated. And there are a number of factors, all the things that Dr. Armstrong talked about, ranging from getting their medications to stigma. And so when we think about the single biggest group of new infections in Georgia is young Black MSM. When you put together the two slides with the disparity by race and by age, that's the group that has the lowest viral suppression rate. I want to talk a little bit about geographic disparities because what we have is this gradient from the northern part of the state to the southern part of the state. This shows the percent of diagnosed people who are virally suppressed in the north, the first three bars, then Metro Atlanta, the central part of the state, and the southern part of the state. And this is a pretty big difference. 61% of people are virally suppressed in the northern part of the state. Metro Atlanta and central districts are similar, around 50, in the lower 50s. And then the southern districts are at 49%. That's a big gap between the southern districts and the northern ones. And because of the racial disparities, I broke this down just to simplify, contrasting whites and African Americans. Whites are shown in blue, African Americans in red, and you can just generally see from, as well as you can see that slide from here, from where you sit, that there's a gap pretty much in every district with lower suppression among African Americans. And we see a similar gradient both for whites, suppression was 65% in the north, 48% in the south, and for African Americans, it was 58% in the north and 49% in the south. So there's about a 10 percentage point gap in both groups, north to south. And if we then focus on those people who are showing up at clinic and how are they doing with their viral suppression, we again see variation with this north to south gradient, and the north is at 92%. Metro Atlanta and central Georgia are both at 87%. And the southern districts are at 83%.
Let me ask a question on that. On these disparities in the south part, lack of education, higher African American population, what else do you think is the reason?
I think it's a combination of factors. I'll discuss that a little more in a minute, but I think it's a combination of factors. But even though it is a higher percent African American in the south, we do see that even when we just look at African Americans, there's a difference between the north and the south.
Okay. Lack of availability of treatment or centers, or just this combination of all
some
these?
of that is limited by what we can actually answer, but
Okay.
I think that there's probably kind of a perfect storm going on in the southern part of the state where it's multiple factors are acting, and they affect all parts of the state to some effect, but probably to some extent, but are more in operation in the southern districts.
Okay.
Does that make sense?
Yes.
So just again to show you that these disparities exist throughout the state as far as suppression among people retained in care. So for example, African Americans in the southern part of the state, 81% among those coming to clinic were suppressed compared to 88% in the northern part of the state. But the disparities are pretty universal.
Warning, you're about halfway through.
No worries. I'm
Okay.
good. I might end up early. So just to summarize, these are actually will repeat comments both that Dr. Felzine and Dr. Armstrong have made about challenges to prevention and to care, issues of limited access to pre-exposure prophylaxis, certainly in parts of the state outside of Atlanta, except for those that were mentioned earlier. There is an ongoing perception that HIV is an urban disease, although clearly our data show that it's not limited, and certainly not limited to Metro Atlanta. And then as far as clinical care, issues related to workforce capacity, inability to hire staff experienced in HIV, provider shortages and having part-time providers, high staff turnover, and stigma and discrimination. And, you know, we do hear from clinics that they get patients from other districts who just don't want to be seen in their home district.
The disparities in
Mhm.
care, you were talking about people in care getting their
Right.
medication. So, I mean, they should,
Mm-hmm.
hopefully wouldn't have been that discrepancy.
Well, there are some disparities about people not coming into care. There's two layers of disparity.
Right.
There's coming into care and then being in care and for some reason being less adherent. We have a more detailed study. Surveillance is a mile wide and half an inch deep. But we have a more detailed study where we looked at people's beliefs around treatment, and we did find that in less urban areas, people were more likely to not believe that medication was going to help them. So there are some issues related to that. And those people, not surprisingly, were less likely to be suppressed because, you know, if you don't think your medication's going to help you, you might not take it.
As regularly, or those, and that
Yeah.
affects the ones in care coming
Yes.
in.
Yeah.
Too. Okay, thank
Yeah.
you.
Yeah.
Yeah, go ahead. Susan.
Did you see any trends in that group regarding faith initiatives or any other reasons to create that kind of disparity amongst the geographics?
You know, that's not something we have good information on. We probably would need to get it through a mechanism like focus groups or something like that. But it'd definitely be an important thing to look at.
Thank you.
So I wanted to switch gears at this point, or if you had more questions about Care Continuum, we could talk about that some more.
Over here on my side, Dr. Price.
Thank you. My thinking sometimes goes in strange directions, but before you proceed, if you wouldn't mind commenting on the surveillance of partners, tracking of contacts, that sort of thing. What are we legally able to do? And I don't want to say the quarantine word, but I guess I just said it. I mean, is there an ability, since I would guess that public dollars are expended heavily in prophylaxis and treatment of this condition, so we have a public interest in curtailing the spread.
Right.
What would you advise, or are there any methods, you know, legally that we could do that would curtail the spread?
Well, let me tell you about a few things that we're already doing and things that we plan to do. So there is an activity called Partner Services that involves talking to people who are newly diagnosed with HIV and asking them to list out partners. And they are given the choice either to list out partners for a public health worker then to go talk to and tell them that they've been exposed to HIV, or they may go and talk to their partners themselves. And as this is out of the sexually transmitted disease program, those staff in the districts do that work. And then also in the course of doing their work, it's not uncommon for them to come across people who already have HIV, and then they work on linking those people back into care if they're out of care. One of our goals for the next several years in Georgia is at this point, the Partner Services activities are focused on people who are diagnosed in public health settings. And sometimes it'll happen that a private provider might diagnose somebody and ask the health department for partner services. What we want to do over the next few years is expand the partner services to all new diagnoses. So that's an important activity. And it also helps identify newly people who hadn't yet been diagnosed and get them into care. Another activity that we will be beginning soon, and actually a pilot has already occurred in Fulton County, is to try to find people who, as far as our records, look like they're out of care. Find those people and try to get them assistance to get them back into care. Since, as we know, those people who are diagnosed but not in care are an important cause for ongoing transmission.
Yeah, it seems to me it's almost frightening the number of people who are living that are potentially carriers. Well, they are carriers, but potential to spread, whereas when in the past they died more readily, and then at that point they were not posing a risk. So we've got a huge population posing a risk if they're not in treatment.
Right.
Did you get your question answered?
I think so, thank you.
Okay, go ahead.
All right, I wanted to, assuming I have a few more minutes, say a few words about injection drug use and HIV, because we have some, we participate in a CDC-funded project where we interview at-risk people. Every year it's a different target population. In 2015, we interviewed injection drug users. And as I said, this is a CDC-funded project. We're one of 23 project sites. In 2015, there was a big push from CDC to all the sites to try to reach more younger injection drug users, because the population that had typically been interviewed in the past was older injection drug users. And so we did, the team in Georgia did a pretty good job and was able to recruit over 120 of these younger injection drug users that are, by the way, harder to find. They don't live in the same places. They're demographically, they're pretty different. The older injection drug use population tended to be more than half African American. The younger population is largely white. They tended to live outside of just the central area. And there were some interesting patterns comparing the younger group, younger defined as 35 and under, compared to the older group. Almost half of the younger group reported a previous painkiller addiction before turning to drug injection. And then the younger folks were also substantially more likely to report sharing needles and sharing equipment being cookers, cotton, etc. Luckily, many fewer of the younger group were HIV infected. This slide shows hepatitis C testing rates and self-reported hepatitis C, and as well as HIV. The vast majority had been tested for hepatitis C, and 36% of the younger group, compared to 42% of the older group, reported that they had been told they had hepatitis C. Much higher than the reports reporting HIV. And this is related to what Dr. Armstrong discussed, is that hepatitis C is very transmissible. It's more transmissible than HIV. It's kind of like an early warning sign. And so this is a report that CDC published, first made available 2 years ago and published last year. And this was in the wake of the HIV outbreak in Indiana. They looked at counties based on a number of demographic factors that were at risk for similar outbreaks. You can't see that well on this slide, but 4 North Georgia counties were highlighted. The Appalachians were, of course, the area of greatest concern. But what I want to point out, too, is that this map shows hepatitis C infections on the left in baby boomers, so an older group, and on the right in people 30 and younger. And we do see that the northern part of the state, darker colors means higher rate of diagnosis. There is something clearly going on in the northern part of the state, but look at the southeastern part of the state, too. And so I think it's really important to not just be limited at to those counties highlighted in that CDC report, because what we know about hepatitis C transmission, we know that the majority of the hepatitis C patients who are interviewed report injection drug use. So this raises the potential for more HIV transmission also in those parts of the state. Yeah.
A quick question about 2 slides back, the one with the entire map of the U.S.
That one?
No, one before with the, that one.
Yeah.
Now, if you look at the Northeast, I mean, people are very close in access to whatever that is that's going on there. Whereas in the South, where the worst rates are for new cases, you know, Atlanta's like the nearest place that's also in this study project is what, Miami or Memphis? I mean, that's kind of,
Yeah.
it's no wonder they're doing well in the North. So how did that happen?
I can't really speak to that. That's a good comment.
Are there studies, we have, sort of approached needle exchange programs, and they haven't gone anywhere in the House. Are there studies that would back up the fact that if we had a needle exchange program, we would drastically reduce the number of hepatitis C infections to start with? And then if you're saying once you have hepatitis C, that I guess that would lower your immune system and you'd be more susceptible to
No,
HIV.
actually what I'm saying is that hepatitis C, there's not a direct relationship between why somebody would get hepatitis C and HIV. Hepatitis C is more like a warning sign
Okay.
that there is in fact unsafe needle sharing behavior occurring.
Okay.
And so if people are sharing needles, the first thing that'll happen is they'll get hepatitis C. And as a matter of fact, for hepatitis C, even just sharing equipment, like cookers and things like that, because it's so transmissible. So it's really more like a warning sign than a direct relationship. And what I wanted to just close with here is showing that our number of cases among injection drug users over time has generally been declining. And this is similar to the rest of the country. And this is broken down by age group. Though in 2014 and 15, we've seen small increases in 20 to 29-year-olds. And that's something we're keeping a close eye on, that we're concerned about. So things to watch out for.
Isn't that the same population where there's an increase in drug use? Or
Right.
one of them
Exactly.
in the same
Yeah.
area?
Yeah.
Okay.
So that's why we're concerned about that and keeping an eye on it and looking for places in the state where this might be clustering or not.
Well, and you didn't answer my question about needle exchanges.
Oh, yeah, needle exchanges are effective.
Okay,
And
even though you can't get to the equipment, certainly at least the needle exchange would be a positive step forward.
Yes, absolutely. At this point, what they're doing in the districts is educating patients about, rinsing out their equipment and things like that, which is kind of a scary thought.
Okay. What about tattoos?
tattoo parlors? Any implications there?
Tattoo parlors are not actually, Wendy, tattoo parlors, I'm not sure if there's been documented transmission.
Yeah, I think that most reputable tattoo parlors now have disposable needles and so on. And so certainly backdoor tattoos are an issue.
Right.
But,
Right, you wouldn't want to go get a friend doing it. But
Or like
Yeah.
they did during the Vietnam War over in that area of the
Yeah.
world and so forth. Caused a lot of trouble. Dr. Felsing.
I'll make further comment if you don't mind, Dr. Wortley. I appreciate the presentation was fantastic, and thank you for the time, Madam Chair. So yes, there is a ton of literature available for needle exchange. And if you look at the Australia, where they started needle exchange early in the epidemic, their transmission rates of HIV are less than 1% in that population. They also have drastically decreased rates of transmission of other bloodborne pathogens, because as one of the maps that Dr. Wortley had shown, in these areas of IV drug use, there could be as high as 80%, and I've seen some areas, especially in Russia, 90% of the IV drug use areas are hepatitis C positive. So yeah, there's plenty of data. Massachusetts has good data on needle exchange also in decreasing those. So I'll just make mention of those, and I'll mention here also that the Georgia State ADAP has several of the oral hepatitis C agents on formulary. So that is a program that is available for those individuals who access ADAP and Ryan White Part B services. But I also wanted to ask you, and if you could make comment, if you don't mind, since we have had phone calls and we've had communication with facilities who do not have IV AZT on hand, they don't have liquid nevirapine, AZT, and lamivudine for babies born to high-risk mothers. If you could just make comment, since you've made comment on other programs, on the perinatal transmission work group.
All right, so the HIV prevention and care program has started a perinatal work group, and we're focusing on two different aspects. One is focusing on providers and getting information to them, and part of that is also evaluating facilities to see, do they have all the protocols and policies in place needed so that the right thing happens. There are about 50 birthing hospitals in Georgia. The majority of HIV infected women deliver at fewer than 10 of those, but then there are a lot of other, what that means is then there are a lot of other hospitals who see very few infected moms appear. And the problem with that is that in medicine, the more you do something, the better you do it. So it's that little hospital that sees one HIV-infected mom a year that we worry about. So that's one part of the work group. And the other part of the work group is looking at really how to manage the patient better and create better links between providers. So for, prenatal care provider and HIV provider, and looking into how to do a better job retaining mothers in care, because as I mentioned, a good chunk of the women who transmit are women who were already diagnosed but didn't get any care, didn't get any HIV care during pregnancy. And so then the right things cannot happen to prevent transmission. So there's a lot of different parts that need to be impacted there.
Well, I think one of the problems with that, if I'm correct, would be the lack of prenatal care. I just talked to a Mercer faculty member who used to work in Albany and is so concerned because she sees mothers that are at 28 weeks, 35 weeks, and have had no prenatal care, that she now goes back from her faculty position and helps them cover on the weekend, even on a Saturday. So even if she can only work 4 hours, and she can see these mothers and get them some prenatal care. And that's one of our problems in our rural areas, that there is a lack of this prenatal care. I mean, just late diagnosis.
And I've reviewed the charts for the infected women who gave birth in 2016 outside of Metro, and just looking at these charts, these are clearly complicated patients who not only, often have a host of medical problems, but a whole host of social problems, and it's challenging.
Did you collect the data on how late they got their first prenatal care?
Yeah.
So do these tend to be really late in the pregnancy?
There's a range. I mean, there's definitely a group among, the information I showed you was for cases where transmission happened. So that's where things went wrong. There are a lot of women where everything goes right and they're in care before and they don't transmit. We will hopefully in the next few months have a report on our 2016 births, all infected women and their babies, and that'll give a better sense than just this group where transmission happened.
Okay.
That's really, where things went wrong.
Representative Bennett.
Thank you, Madam Chair, and thank you, Dr. Wortley. You may have answered this, but I want to go back to the question that Dr. Price presented regarding the prevalence in the disease in the north versus the southeast. And we saw on your map that there was a cluster of projects, support programs available. Do you think that it is something as simple as adding more programs in the southeast that will remedy that or narrow the gap? Or are there other factors that you see from the northeast versus the southeast that may be barriers to improvements in this area?
You know what? I'll just go back to this map because I think there's maybe a little confusion about what it shows. These projects are this activity we do where we interview people at risk to collect data. So it doesn't really have a direct impact on care received in those areas.
Yeah,
Now, you know, you bring up a really good point that, of course, there is a high density of, you know, these project sites in the Northeast compared to the Southeast, where we know that we have a very high disease burden. And, you know, I don't really know why it is that other states didn't apply for the funding, or I really can't speak to that. And I think that's a great observation. But I don't think that having this project per se specifically in those locations is having, you know, is responsible for the disparity in disease that we see. It's much more, there's a lot of different factors that play into that. This may, you know, be an indirect reflection of some things, but
Thank you.
sorry for not being able to answer that better.
Okay, Dr. Felzine, I'll give you the last question.
All right, thank you, Madam Chair. I just mostly wanted just to make a comment off of yours of the provider down in Albany, and prenatal care is so important. And depending on which journal you open and which textbook you open, I mean, transmission can be as high as 20% in that population, higher if they're getting HIV in their third trimester. So thus the law that everyone that you're involved in pushing to get those type of testing. But we can't forget the women that are showing up late. And it can be as high as 20% during delivery if the child is not getting medications after discharge that we're seeing. And I want to make one last point, just because this is such a complex and multifactorial process that Dr. Wortley has said. I have my patients coming back and saying that they are required to go through breastfeeding classes before they can access other state programs. And my HIV-positive clients are feeling stigmatized. They are feeling discriminated against because nothing is mentioned about HIV. And in this country, we do not promote breastfeeding in our HIV-positive women. That is a World Health Organization recommendation for third world countries.
Okay, if you want to give me the specifics on which program you're talking about requiring that sounds like a state requirement. See what we can do.
I'll get that to you.
Okay. That sounds like, I mean, we're looking for doable things we can do, and that one, if it's counter-indicated for HIV mothers, which it definitely is on transmission, that shouldn't be a requirement. They sit and go through that kind of training at the time. Thank you. Thank you very much, Dr. Wortley, for coming for us.
Thank you.
Appreciate your presentation. Dr. Purcell. Thank you for being with us, and if you'll introduce yourself and who you're with.
Yes.
We do have one on this one. Okay, you need to set the timer when he starts. Right here.
Good morning.
Good morning.
I'm David Purcell. I'm the Deputy Director of Behavioral and Social Science in the Division of HIV/AIDS Prevention at the CDC. I'm here with two of my colleagues, Sheila Salvant-Valentine and Patricia Sweeney. We're glad to be here today. Quick disclaimer, which is in front of many CDC presentations. For the record, our staff attending today's hearing are not making this presentation for or against any specific legislative proposal. So I'm going to give you a very brief overview of HIV prevention in 2017. The previous two presenters have done a great job of that, so I've kept mine very brief. Then talk about HIV criminalization laws and read some research we did on the link between criminalization laws and HIV or AIDS. So in terms of HIV prevention in 2017, I'm showing this slide of AIDS cases over time to reiterate a point that some of you already made on the panel, that as new treatments came in, number of AIDS cases and deaths declined dramatically, and prevalence, or the number of people living with AIDS or HIV in the United States, increased dramatically. So that's an important point that indicates that there are a lot of HIV-positive persons living long, healthy lives now in the United States. This shows national trends in HIV diagnoses over time from 2005 to 2014. And what it shows is dramatic decreases among heterosexuals, injection drug users, as well as men who have sex with men and also use injection drugs. It shows a fairly flat trend at the top among gay and bisexual men, or MSM, but this flat trend hides some differences by race. We actually see decreases among white men over time, a fairly flat trend among African American gay and bisexual men since about 2010, and increases among Latino gay and bisexual men. This shows the rate of diagnoses in the United States, and this point has already been made. This, among states, Georgia has the second highest rate in diagnoses for 2015. And this breaks the rates down by region, and you see that in the South, with cities above 500,000, the rates in the South are approximately double the rates of similarly sized cities in other regions of the country. And when we look at smaller cities or non-metropolitan or rural areas, we see the rates are approximately triple the rates in the other regions of the country when we look at the South. So it's, again, the points the other speakers have made, it's not just a big city issue in the South, it's also a rural and small city issue. So HIV prevention in 2017 actually gives us many exciting options because there's more prevention options than we've ever had. So biomedical prevention, HIV medicines or antiretroviral treatment for HIV-positive persons, which have profound health effects, as well as the prevention benefits you've heard about, and then PrEP and PEP for HIV-negative persons. There are still other prevention options which we CDC support. All of these: abstinence, condoms obviously help protect against sexually transmitted infections, syringe services programs, choosing lower risk sexual behaviors, as well as partner selection strategies such as serosorting, where partners choose a partner of the same status of themselves. Focusing briefly on biomedical prevention for people with HIV, 3 recent studies found 0 linked HIV infections from sexual behavior while the person with HIV was virally suppressed or undetectable. This is over extensive follow-up time, covering many thousands of condomless sex acts and no or virtually no PrEP. On the other hand, as the previous speakers have shown you, longitudinal data show that a majority of persons in consistent care are virally suppressed, but viral load suppression is not universally maintained even by those who are in care. We see that 1/3 of patients nationwide are not suppressed consistently, and about 20% are not suppressed at their last viral load test. So putting these 2 pieces of data together, we know that treatment works. It actually works really, really well, but not everyone is fully benefiting from antiretroviral treatment, either personally or protected from transmitting to their sexual partners. CDC recently reviewed its messages around HIV medicine for people with HIV. We did this as part of a cross-federal work group led by the Department of Health and Human Services. Our treatment messages developed by this work group are as follows. Treatment greatly benefits the health of people living with HIV, and current guidelines recommend lifelong treatment. A key goal is to get viral load down as low as possible. And when treatment is taken daily as prescribed and reduces viral load, the risk of sexual transmission is also reduced. In terms of our specific prevention message, and we just released this a couple weeks ago, people living with HIV who take HIV medications daily as prescribed and achieve and maintain an undetectable viral load have effectively no risk of sexually transmitting the virus to an HIV-negative partner. The biomedical prevention for HIV-negative persons, just to reiterate prior points, PrEP is an HIV medicine taken daily by HIV-negative persons, which provides very high levels of protection against HIV infection, but it's very important to adhere to the medication for it to actually work. And then post-exposure prophylaxis is HIV medicine taken for within 72 hours of a potential HIV exposure for a duration of 30 days. This was developed in the healthcare setting to take care of accidental needle sticks, and is now used non-occupationally. Consumers can obtain PEP from health departments, providers, or ERs. Now shifting to HIV criminalization laws. Just a little bit of history and background. As you know, in June of 1981, CDC identified the first 5 cases of a mysterious disease that would later be called AIDS. And just 4 years later, the first HIV test was developed so that both people and blood products could be screened for HIV. Once people could be identified as having HIV, the first criminalization laws were introduced the next year. And the basic legislative intent was to punish various behaviors by people living with HIV that were believed to spread HIV. In 1990, the Ryan White Care Act legislation required states to certify that criminal laws in their states were adequate to prosecute those who knowingly exposed others to HIV. By 1995, most state criminalization laws that were going to be passed had been passed, the HIV-specific laws. In the 1990s and up through the 2000s, the context was a little confusing because public health was promoting testing and data sharing. At the same time, laws were being passed about privacy protections and criminalization laws. So there's this tension. In the 1990s, laws were passed to promote privacy and the privacy of public health information, but also there was promotion of testing laws. So in 2006, CDC revised its testing recommendations in healthcare settings to suggest opt-out screening for everyone in the US aged 13 to 64 at least one time and annually for persons at higher risk. In 2010, the National HIV/AIDS Strategy was released, which suggested that states reconsider criminalization statutes to see if they are consistent with current knowledge about HIV transmission and public health approaches to HIV. By 2016, 30 states had HIV-specific laws. So in our division, we have a legal assessment project which reviews laws that affect HIV prevention, such as HIV testing laws, laboratory reporting laws, consent laws, confidentiality laws, syringe service program laws, as well as criminal exposure laws. This is an ongoing project. There's a website that you can see some of the work that's done there. I'm going to talk about two recent papers that we've published today. The first was published in 2014 with data on the laws up through 2011, and we've updated that data up through 2016. This shows that 30 states have HIV-specific criminalization laws, including Georgia. 9 states, have infectious or contagious or communicable disease laws that can be used to criminalize HIV. And in purple, 12 states have no laws criminalizing HIV, but general criminal statutes have been used in almost all those states to criminalize transmission risk behavior. And one important point to note, in terms of the classification of the crime, they range from misdemeanors in some states to felonies in many states. In the Georgia law, the following behaviors are penalized: sexual exposure, needle sharing, prostitution or solicitation, donation of blood, tissues, and fluids. There's also an additional law: biting, spitting, throwing up on either a peace officer or correctional officer engaged in his or her official duties. In terms of when we look across the US, these are the behaviors that are penalized in state laws, and the N equals the number of states that penalize the various behaviors. Some of these behaviors are higher risk behaviors, as you heard Dr. Armstrong talk about. Some of these behaviors are low or no risk behaviors. In terms of Georgia penalizes all of these behaviors, 4 high risk behaviors, and these lower risk behaviors, the only one it doesn't penalize is sharing sex objects. States also have disclosure requirements in some of the laws, as well as defenses. People with HIV must disclose to sex partners in 21 states, including Georgia, and to needle sharing partners in 10 states, including Georgia. And then there's defenses to charges, including disclosure. If you told someone, that's a defense, and the burden shifts depending on the state. Condom use is a defense in 4 states, and being virally suppressed at this point is not a defense in any state. You can see the maximum sentence length varies broadly across states, but tends to be fairly severely penalized. So moving now to the link between criminalization laws and HIV or AIDS. So there's been ongoing discussion since these laws were first introduced about whether criminal exposure laws affect behavior or transmission. Questions like, do these laws reduce transmission by encouraging disclosure or deterring high-risk behavior? Do these laws possibly increase transmission by discouraging testing to avoid the law or because of perceived stigma? Or do these laws have no impact on behaviors because people may not know them or for other reasons? So an ecological analysis of structural interventions, such as policies or laws, is a useful type of analysis, a useful tool for assessing public health impact. For example, there's been a lot of research on alcohol policies and STDs showing changing your tax, increasing your tax on alcohol decreases STDs. So our objective was to assess whether state criminal exposure laws are associated with HIV and AIDS diagnoses rates in the US. And this was a paper published earlier this year in the journal AIDS. So we identified laws through Westlaw Next service, updated through 2014, and we used AIDS and HIV diagnoses reported to our national HIV surveillance system. We used HIV diagnoses in 33 states, because those are all the states we had with complete reporting through 2010, and AIDS diagnoses in all states from 94 to 2010. We also added some social and economic data from the US Census Bureau, and then we did a fairly complex statistical analysis, which I will not belabor you with. So the results showed there was little change in the number of states with laws over this whole period, so it increased from 27 to 30. We found that urbanicity, which means the proportion of the state that's urban, unemployment, low education, poverty, and minority population proportion were positively and significantly associated with HIV and AIDS diagnoses rates. And then when we did more complex modeling to try to take out the overlap between all those correlates, low education and urbanicity were significantly associated with HIV and AIDS diagnoses in adjusted models. However, criminal exposure laws were not associated with HIV or AIDS diagnoses over time. So our conclusion was the criminal exposure laws in the US had no detectable HIV prevention effect. The analysis supports the hypothesis that these laws have not affected behaviors or transmissions. Some of the limitations of any sort of ecological analysis, just to note, is that they reveal associations but not causation. We did not include a detailed categorization of the law, so the laws were categorized, states were categorized as having a law or not having a law, but as you saw earlier, there's a wide variety in the types of laws people had. And local factors related to implementation of laws were not considered. So states without a law may have had a criminal statute that they enforced. So that was difficult to be sure we were capturing all of the criminal prosecutions in the state. To conclude today, HIV treatment is more powerful than ever, both for the health of people with HIV and as a prevention tool for sexual transmission. HIV-negative persons have more prevention tools than ever. HIV diagnoses are decreasing in most groups nationwide, although we see an increase among Hispanic, gay, and bisexual men. And prevention and treatment are working, particularly in jurisdictions that are trying to maximize the range of prevention tools. Dr. Armstrong showed the picture of San Francisco over time. That trend has continued with more recent data that was recently published. And the final point, policy tools may have the ability to enhance HIV prevention. Again, there's no evidence that HIV criminalization laws have a prevention effect, but other possible intervention targets might include access to and utilization of care, stigma reduction, and medical distrust so that people can access the powerful range of biomedical and behavioral HIV prevention tools. Thank you.
Thank you very much. I have a question. In the studies, are other states, has there been a movement to take a lot of laws off the books across the country?
There has been some movement. California changed its law last week. Most of the movement has been from moving from a felony to a misdemeanor, or sometimes expanding the law to actually include other diseases, which one state did. So there has been some movement across the states as they're trying to reconsider whether these laws make sense in today's context.
I mean, are these criminalization laws, and I may have missed this, used frequently? Or are they sitting on the books, and as we've gotten better at treating HIV, are there less use of the laws, but they're just sitting there? Because, I mean, we have laws we found from 1890s that sit on the books and they're never used.
So there's a steady stream of cases across the country using these laws, whether it's the HIV criminalization laws or using a criminal statute to punish potential transmission behavior. We get emails all the time from people wanting more information on, I was virally suppressed. Can I use that as a defense?
Okay. Does that happen even in the states? I mean, the white states that didn't have any laws, or the purple states that didn't have any laws, are you getting
They're
report?
using criminalization laws.
Criminalization
yeah,
laws.
Texas has a number of criminal cases, even though it has no law. Again, that's this concept of HIV-specific laws, general STD laws, and no laws. Each of the states can still find in their statute ways to criminalize the same behavior.
Well, I know I said something about spitting this morning, and that, we know that HIV can't be transmitted by somebody spitting on you, and the officer said, well, but there's laws about spitting
Right.
already on the book. So, that was the immediate response I got from the officers that were
Yes.
running the building this morning. Representative Price.
Yes, thank you. Even if people aren't in the non-transmissible level of viral load, are we seeing less complications in terms of, the immune issues that are also costly?
So if they are virally suppressed, or
Well, anywhere on that spectrum.
so the lower your viral load, the better your physical health. Much fewer complications, if any. People can live a natural lifespan.
So we're seeing a whole lot less of what we previously considered the sort of stigmata of AIDS.
You're not seeing Kaposi, sarcoma, and
Right.
things like that nearly as much. But again, we still have a chunk of people who report to care very late. So they arrive and they not only are diagnosed with HIV, but also diagnosed with AIDS. And so it just depends on when you report to care. But the earlier you get in care, the more likely you're not to have any of that sequelae.
So if someone doesn't show up for an appointment, what are they searched for, or if they don't renew their prescriptions?
So I think it depends on the clinic. That's one of the CDC initiatives is called Data to Care, and Dr. Wortley alluded to this. We're really trying to use, so historically surveillance data has been used just to count cases, and surveillance data is now being used for public health purposes. So state health departments are now using surveillance data and using lack of showing up to care to have navigators go out and try to find people. So it depends on the resources in the state, but we're funding a number of data to care projects, and all state health departments in the country will be funded for data to care under our new program announcement that'll be starting in January.
Boy, that's really innovative, isn't it? That we share information from the different silos
Yes.
to
Yes.
benefit the patients. I'm
Yes.
being sarcastic, but it happens in state government and federal government. You've got a silo here and you've got all this information,
Right.
but it's not
Exactly.
transmitted to where it might be actually put into action.
Exactly.
So it's really good to see that.
And
those
they're trying to
programs
do
are
data to
coming.
care both ways. So, because sometimes to the clinic, my patient didn't come back, but it's because he or she didn't like the patient, and he's in care somewhere else, and the state can tell the clinician that John is not out of care. John's at another clinic. He's still in care. So this bilateral dialogue between providers and state surveillance departments is increasingly encouraged to figure that kind of thing out, so that people know whether people are in care and whether they need to actually be followed up.
And I think somebody, talked about using people in the community to go out and try to find people. Are we finding, in the African American community, which is one of our high areas, is there a resistance? Is it hard to find peer people, or not peer people that have AIDS perhaps, but which I think would probably work better if somebody was on medication and could become a person to go out and talk to other people about it. But is it difficult to get people from those communities, since there's sort of a stigma with the religious part, often in the South and African American churches, to get other African Americans to work in this area of outreach?
I don't think so. There's tons of African American outreach workers. To me, the issue is, as HIV has become increasingly medicalized, we often see disparities as a disease becomes more medicalized, because certain communities distrust the medical community more than others, and there's a historic medical distrust in the African American community. And so a lot of our CBOs are doing, and what we're feeling as a great role for them, is working to engage the community in non-biomedical ways, and then over time link them to biomedical options. So getting gay black men to take PrEP has been very challenging. It's often because they're not comfortable in a medical setting, don't want to go straight to a medical setting where they may not feel comfortable. So often a community-based organization can engage them in ongoing group sessions around various issues relevant to them, because PrEP isn't that relevant to them, and then over time engage them and then walk them down the street to the clinic because they trust the provider, the CBO provider, to link them to a provider that they trust.
Okay. Dr. Graham.
Yes, thank you, Madam Chair, for asking the question earlier about the criminalization laws, because as I was looking at that, it clearly has not had an impact on prevention or transmission. But if we look at the population that's most impacted, we're looking at African American men. So given that the states are using the laws, I think it begs to question, is this another avenue in terms of the disproportionate incarceration of African American males using this law, which really has not had any impact in the medical community or in transmission, and is that really something that we need to look at as a state? My other question regarding that is, have those laws ever been used to look at women who are known impacted by HIV, who are transmitting it to children and not in treatment or refusing treatment or non-compliant?
Let me start with your second one. I don't think it has been used in that case. That's an interesting question. Would it be a crime to pass it to your child because you weren't in care? I don't think that, because that's not a transmission route that's listed in the statute as a crime. So I don't think that has been used, at least in our state. It may have been used in another state, but I haven't heard of that. In terms of I'm not sure. I don't know that there's enough cases to know the racial breakdown of the cases, but there's been some writing that it feels like the criminalization laws are disproportionately used for African American gay and bisexual men than other races. There is some discussion of that in the literature, but I don't know if there's enough data to say that if that's the case or not.
I think it's something we definitely need to look at.
Yeah, absolutely.
Do you have any information at the CDC that indicates how often Georgia uses any of these laws?
I don't think we do. The issue with at a national level tracking what happens at a state level is very challenging because often it's it's not even reported. A lot of these cases would never be reported, so there's not a national reporting system. So you tend to hear about them when they make the news or when there's a big to-do. But I think they're used in cases where we don't hear about them. So, but I think in general it's not used a lot, but there's, again, this steady drumbeat. You still see cases. There's cases going on currently in other states.
Well, I would certainly think just the fact that they're on the books and they're used occasionally could be seen as a deterrent to people coming forward for treatment and being more obviously out about being HIV positive or having AIDS if they know that there are criminal laws.
I mean, that's the question. But that could potentially be
a problem.
Be a problem
for seeking treatment and this kind of thing. Because once you start treatment, you're trackable.
Right.
In some degree or other, that would be able to be tracked. I wonder if that's a major. Representative Bennett. Okay. Last question.
Thank you again. And that's a great point of how data and evidence helps as well as hinders the access to care. My question was, I know we referenced the different categories where you do the statistics. You have minority, you have low education, you have low economics. I wonder if there's any cross-referencing of that data, or is it duplication, or how do we separate?
So, yeah, that was one of the statistical points that's a little bit hard. So if you look at the second bullet here, a number of different factors are associated with HIV diagnosis rates. So if you're more urban, you have higher rates. If you have more unemployment as a state, you have higher rates. If you have low education, you have higher rates. Poverty, minority population. So, but those things are overlapping. They're overlapping Venn diagrams. So statistically, you can take that overlap out. And when you take that overlap out, the next bullet, the thing that remains are low education and urbanicity. So a state that has lower education or is more urban has higher HIV/AIDS and HIV and AIDS diagnoses in adjusted models, but again, not associated with criminal laws. So education and is important in terms of HIV and AIDS rates. Thanks.
Thank you very much.
Thank you.
And I appreciate you coming and taking your time today to share this with us. And I will say to the committee, I mean, the presenter sent Leo very detailed information and slides. And he will send a link to it so that you can go. I know one of them is 60 pages long. We chose not to print those, but you should be able to find answers in depth if the ones you would like to look, and I appreciate the presenters doing that. Okay, and next we have Ms. Causey, Maisie Causey.
Good morning.
Good
Hi,
morning.
yes. Thank you so much for the invitation to be here today. I'm Maisie Lynn Causey. I'm a lobbyist with the Georgia Association of Criminal Defense Lawyers. Some of what I have included in the presentation that you'll have has been covered today, so I'm certainly not going to be redundant, and I will save your time as much as I can and hopefully answer a few of those questions that just came up in the last presentation. I do want to touch on the specific history here in Georgia. In Georgia, our law was enacted in 1988. In that initial enactment, our General Assembly recognized a few things that some we know to not be true and some we know to be true now. We are 30 years later after all. And that is that at that time, the belief was, and the reality, because we didn't have the advances that we have now, that HIV and AIDS threatened almost certain death to all who contracted it. We're in a very different time now. The General Assembly certainly recognized that education is key to the fight here, but ultimately its stated intent was to use its police powers in order to deal with AIDS and HIV infection. Now, I would argue that if we unpack that notion of dealing with AIDS and HIV, that what we want to do is strive to make policies that serve to reduce the transmission of HIV and AIDS and infections in our state. As was mentioned before, after we enacted our law, it went into effect July 1, 1988. That's when some of the federal suggestions about these laws came about. The Ryan White Act came about in 1990. Again, requiring that states certify that they were prosecuting the intentional knowing exposure of HIV. What you will find when we get to the details of our law is that intentionality is not part of it, even to this day. The certification requirement was the way that states accessed the funding at the time. In 2000, that funding carrot was taken away. So we no longer have this certification requirement that we have laws on the books to prosecute these types of transmissions. Later in 2003, our law was expanded, and this is the expansion that was mentioned with respect to peace and correctional officers in the line of duty, assaults against them using spitting, feces, vomit, etc. And as you've heard, beginning in about 2010, the federal government began pulling back on this suggestion that we criminalize this behavior and begin to look at the ways that our laws are or are not preventing the spread of HIV and AIDS. I've been relying on errant data from a surveillance fact sheet from 2015, but as we've heard today, we are actually the second high in the nation for the new infections of HIV and AIDS. We know that the stigma of a positive status remains very high, and fear leads to avoiding the knowledge of your status, failing to disclose your status, barriers to accessing treatment, and ill-informed media accounts that contribute to misinformation. So, for instance, if someone is prosecuted under our law regarding spitting on a police officer, and that is then put into the newspaper, we are just perpetuating this misinformation that is actually a way that the virus is transmitted. Because after all, why would we legislate behavior that actually doesn't line up with science? The general public doesn't expect that to happen, but because it has happened, this misinformation can be spread to the community in that way. Ultimately, and what we're here about, this committee's here about, is that these all are barriers to access to adequate health care. And this should say that the CDC says that stigma hampers prevention, not sigma. Sorry, I've lost my... So I'm going to take you through to our current law. Our HIV criminal laws fall under our general reckless conduct law. The general reckless conduct law is a misdemeanor, and this applies to every Georgia citizen, regardless of your HIV infection status. If you cause bodily harm or endanger someone, and the way that you've behaved or refrained from behaving is a gross deviation from the reasonable standard of care, you've behaved in an errant way, you could face up to a year in custody and up to a $1,000 fine. It's kind of it's a slap on the hand in the scheme of criminal laws, misdemeanors are. And of course, all criminal law is meant to prevent behavior that we don't want. It's not really there to encourage the behavior that we want, which is really what we're hearing today that prevention's all about. It's encouraging the right behavior. If in Georgia you have knowledge of your infected HIV status, oops, sorry, I skipped one. If in Georgia you have knowledge of an HIV infection and you knowingly engage in various sex acts without prior disclosure, share needles, perform sex acts, solicit sodomy for money, donate blood products, all of these things, if you do it with knowing your status and without disclosure, you are guilty of a felony. You can be penalized up to 10 years in prison. And again, this idea of the intention to transmit or expose someone to HIV is not in our law. The only thing you must intend to do is the act, the sex act, the needle sharing, the donation of blood, etc. And then this is where in 2003 we expanded our felony code section so that if you have knowledge of either HIV or hepatitis infection and you assault, here we did add the intent, with the intent to transmit against a peace officer or a correctional officer using blood, semen, vaginal secretions, saliva, urine, or feces, which we have heard today and we now know are not viable means of transmission, you're again guilty of a felony. The minimum amount of exposure to prison or incarceration is 5 years, up to 20 years. It's also notable that just this past session, our legislator passed another law that criminalizes this kind of behavior. Any Georgia citizen who assaults a public safety officer, which includes these peace officers and correctional officers, with blood, semen, urine, feces, or vomit, they added, but notice saliva is not on the list, is also guilty of a felony. Here's the difference. It's 1 to 5 years and a $300 fine. So if you take this subsection of bodily fluids, I'll call them, and you are not HIV infected, your exposure, your criminal liability is much less than it is if you're HIV infected. So there's already we've built in some discrimination into how we are penalizing our citizens based on their HIV infection status.
And that's because one of them is a 10-year, up to 10 years, and the other one's 5 to 20?
Yes, ma'am.
Just because there's that discrepancy in the sentencing possibility?
Yes, ma'am.
Okay.
As Dr. Purcell mentioned, we do not have, apart from disclosure, we do not have any other defenses on the books here in Georgia. You know, I've realized that I missed a couple of slides. I must have just, I'll get through these and go back. Of course, it's difficult to prove disclosure. When many of these acts are happening, they are intimate environments where you get into a he said, she said type of defense situation in a courtroom. It's very difficult to defend when your sole defense is disclosure. And when you layer on the biases and fear that come with dealing with HIV, the chips are frankly stacked against you. Here in Georgia, the use of protection, the use of a condom, compliance with your medical regimen, none of that is a defense here in Georgia. And to answer your question, Chairwoman Cooper, since 1990 through last year, the GBI reports that 591 individuals have been charged under these HIV-specific reckless conduct statutes. So this is subsection C and D of the code section. And Dr. Graham, of those, the discrepancy or the breakdown between black and white people affected by this law is 60-40, black to white, 80-20, male to female.
Huh.
Now, this is charged. So this is the very first interaction that someone has with the authorities. This does not account for what happens over time. Some of these cases may be dismissed, some of these cases may be taken to trial, some may plea out. Capturing that data is much more difficult because that is spread throughout the state, all 159 counties. You've got all the courthouses. You'd have to do a search of each individual case to find out what happens in the end, but we know that close to 600 people have been charged.
Okay. Dr. Price has a question,
Yes, ma'am.
clarification. Right
A quick question on those 591 individuals. Are those driven by someone complaining or through tracing?
I'm not sure I understand through tracing.
Well, I
You
mean,
through-
is this like a private cause of action, or is this the state making this charge?
Well, what I can say is that generally encounters with law enforcement start from a 911 call or some kind of request by a citizen for assistance. It's not my understanding that anyone's being surveilled in a way that then they're followed up and caught doing a behavior, if that's what you mean.
No, I'm just trying to figure out, is it the person who contracted the disease that's generating this charge, or is it somehow or other the state, through questioning or whatever, determines that person was the proximate cause of that person contracting the disease?
I would have to look into that more. What I can tell you is some of the reported cases that have made it through the court system and we have court opinions on are things like there's a pretty prominent case, and interestingly, this case was not prosecuted under 16560. It was prosecuted as an aggravated assault with intent to murder, because as you've heard today, we don't have to rely on this particular statute. We can use general criminal laws, and one of those that gets used here in Georgia is this aggravated assault with intent to murder. And in that case, the man's name was Scroggins. It was during his interaction within the correctional context, and he bit a police or correctional officer and indicated through his words his intent was to transmit the disease that he knew he had. So my guess, and I'd have to look more closely, but my guess is that it is generated by just normal complaints. And whether that's someone who becomes infected and reflects upon how that could have happened and goes to the police, and that's certainly a possible scenario. But a lot also with the subsection D, it's just interactions with law enforcement. And so the law enforcement officer is the one generating the charge.
But not through medical routes?
It's not my understanding that medical providers are bringing these types of charges.
Okay.
No, ma'am.
Thank you.
But it is worth noting, though, that although 600, one could argue that 600 people over this time span from 1990 to 2017 is not a relatively high number. What we cannot know is exactly how many people are being prosecuted under the general criminal laws, because we don't have, for instance, a subsection under aggravated assault for HIV-infected people. So when I call the GBI and say, how many HIV-infected people have been prosecuted under the ag assault statute, that they have no way to know that, because we don't code it that way in our system. It's not criminalized that way on our books. We just have to we would have to literally go through every aggravated assault case in the state to figure out if that was the intent of the prosecution from the start. So this, I would guess, is a low number based on what we know about reporting of other crimes other cases that have gone up through our judicial system. I just wanted to go back. I
What, Nan?
inadvertently missed this slide. Is there another question?
Yeah, I just want to clarify thank you, Madam Chair, for the interruption. What you're saying, and also what Dr. Purcell just made mention of.
Mm-hmm.
So is your ultimate recommendation of this going to be removal of this law, since you're stating that it is the main criminalization law? That's one issue. Or to clean this law up to reword it to remove saliva and the things that the CDC says are low risk, and also time in prison. Is that something? Or my question is that going to be your ultimate recommendation? But my other concern is I don't know the other laws. I'm well versed in the HIV laws because of what I do for a living. But is this if let's say magically we had a magic wand today and this law is gone, is that going to push the use of other laws that have criminalization language to be used for these 591 individuals? So these individuals are not going to be now protected because there's other laws that can actually criminalize.
Ultimately, my recommendation in the scope of the presentation today is not abolition. It's reformation. But to your second question, certainly, if this law was just abolished today, that would necessarily funnel any type of prosecution that a prosecutor wanted to bring based on HIV infection into our general criminal laws, and in a way not provide the protection. But I do believe, and I would hope, that any reformation we make, that the General Assembly chooses to make, would include some carve-outs to help keep that from happening even now. That if the intent is to focus on the intentional transmission of this virus, then let's focus on it and not do an end run around it through these other general criminal laws that we, to your point, cannot track, cannot be certain are being appropriately used. And this idea that, for instance, in Mr. Scroggins' case, he bit a man and was charged with intent to murder. It's just not scientifically valid. But it's hard to play that out in a courtroom sometimes for lots of reasons: barriers to funds for experts, lack of understanding in a community. So if we can keep these prosecutions in the context of the laws that are meant to handle them, we should do that. But I think that's going to require just some artful construction of legislation to keep this behavior under this particular code section and try to keep it out of those general criminal law prosecutions. With Dr. Purcell was talking about the article and the research that the CDC has done in partnership with the Department of Justice, and some of the technical guidance that has come out of that is that the states should re-examine their HIV criminal laws. They should make sure that they're not uniquely or additionally burdening those living with HIV, that they should have their policies reflect a contemporary understanding of the science, and to be sure that they reflect the associated benefits of treatment. The big issue is, are these laws the best vehicle for their intended purpose? And now we're back to what's the intended purpose. So let me go back forward. So we've covered the current law, the lack of defenses, and now we come in the CDC DOJ, excuse me, technical guidance is, as I mentioned, we don't want to uniquely or additionally burden those living with HIV. At this point in time, our penalties do that. They enhance penalties against those infected with HIV as compared to the general population that's not infected with HIV, excuse me. We do not fully reflect a contemporary understanding of HIV transmission. We are not accounting for actual risk or prevention measures with our current criminal laws. And we are not reflecting the associated benefits of treatment, for instance, the undetectable equals untransmissible, and in offering defenses or in the behaviors that are criminalized. Ultimately, as I said, the suggestion is that if you're going to keep HIV-specific criminal penalties, these are the places to keep them and nowhere else. That if someone who knows their positive status commits a sex crime where we know there is a risk of transmission, for instance, a rape, that would be something worth considering for a criminal penalty. Or with knowledge of a positive status, someone truly intends to transmit the virus and the behavior that's used actually has a significant risk of transmission. This does, of course, couple with what Dr. Purcell mentioned, that these exposure laws are not effective prevention measures, on the one hand. On the other hand, just like any other criminal behavior or behavior that we seek to criminalize that is an intentional assault or an intentional harm committed against someone, that's where we see criminal laws being meaningful and having impact. We've gone through the rates of transmission. I'm not going to go back through those again, but as you now know, we are criminalizing behavior that is zero risk or negligible risk of transmission here in Georgia. Specifically, we are recommending that we account for intent, which is essentially aligning this law with the rest of our criminal code and actually penalizing the intentional behavior that we mean to, not the intentional behavior, for instance, of just engaging in the act, but the intentional transmission of an infectious disease. And again, as I mentioned earlier, we'd like to preclude an end run around this statute, bring the prosecutions into one place so that we know what's happening with them, so that we're not using aggravated assault, for instance. We are using whatever HIV criminal law the legislature deems appropriate, and we follow their intent. We're asking to account for science, eliminate biting, spitting, throwing bodily fluids, and oral sex. And also, like I said, recognize that the legislature did enact a law this past year that continues to protect public safety officers, but let's apply it equally among all of our citizens. We would also think that there should be a recognition of the role of risk reduction measures, the use of ART, PrEP, PEP, condom use, and that ties into accounting for the possible defenses. If people are using risk reduction measures, that should mitigate the intent to transmit the act. And then also being mindful of sexual assault victims. You know, our law is actually pretty uniquely drafted in a way that when the act happens, if it involves someone who knows that they're HIV infected without disclosure, they are guilty. So you can conceive of, and I know our legislature in different committees has heard personal testimony of sexual assault victims who are HIV infected, who are fearful of bringing their assault to the police because of the possibility. Now, how possible it is, I can't speak to that. I'm not a prosecutor. I would like to think our prosecutors, and the ones I know, would exercise meaningful discretion and not prosecute that victim and add more trauma. The fact is, the law would allow it right now to happen. So a carve out for victims of sexual assault is also very necessary. I don't want to go too far into the details, but I did want to provide it to you. So I've given you in the slides a couple of recent Reformation laws. As Dr. Purcell mentioned, we are not seeing abolition happening across the states. We are seeing some work at Reformation. Iowa reformed their law in 2014. California just signed their new reformed law last week, I believe. But a couple of the important points and things that are coming out of these Reformation efforts. One is Iowa's code defines contagious or infectious disease as HIV/AIDS, hepatitis, meningococcal disease, and tuberculosis. So we're getting out of the singular HIV, arguably discriminatory practice, and recognizing that, as we've heard today, the severe transmission rates of hepatitis. We certainly don't want someone intentionally transmitting hepatitis, but right now, apart from with public safety officers, we are not criminalizing that here in Georgia. Apart from if someone did want to use those general criminal laws, which they, again, could. But the way Iowa has set up their definition is they can add to or take away from this list of diseases as it makes sense. And if there are scientific advances in these other diseases, or Ebola, for instance. We've got new diseases that are becoming are coming to our country in a way that they haven't before. And we, again, wouldn't want someone intentionally transmitting that. And then here's another part where you get to some of the subtleties. Iowa distinguishes between transmission and exposure. Exposure is that which, in Iowa, poses a substantial risk of transmission. Unfortunately, Iowa doesn't define substantial risk. So there are lessons we can take here, too, of looking at ways that we would want to define substantial risk, so that that's not up for a jury determination, that should be a scientific determination. And there are ways to do that. California, I believe, has done that. We'll get to that in just a moment. Iowa also distinguishes between intentional conduct and reckless disregard for the way that their behavior could transmit one of these diseases. And included in their defenses is this, it's hard to read, but practical means to prevent transmission. So for instance, someone who is in good faith compliance with ART could raise that as a defense. If that person can come, they happen to have an undetectable viral load as a byproduct of that good faith compliance, that then is a defense for them in Iowa. And that would be true for any of the care that is available to them for hepatitis or tuberculosis as well. To give you some idea of Iowa's penalty scheme, it is much harsher than ours in some ways. People there who intentionally expose and transmit, if the prosecution can show both intentional exposure and ultimately transmission, it's up to 25 years in prison. If there's intentional exposure without transmission, however, it's only they only penalize that up to 5 years. And I say only, I don't say that cavalierly, but relative to 25, it is a significant difference. And even compared to our 10, it's a significant difference. I'm sorry?
We're nearing the end
Okay.
of time.
And then if there's reckless exposure without transmission, that's a misdemeanor. And as Dr. Purcell also mentioned, that's what we are seeing. And in fact, in California, that is what they did. California no longer has felony penalties for HIV, their HIV criminal laws. And here's what I was talking about earlier. California has defined substantial risk of transmission. That has to be an activity that has a reasonable probability that that transmission of disease is proven by competent medical or epidemiological evidence. So we would recommend this is the type of definition we would want to see to clarify substantial risk of transmission. And if it's low or negligible risk, things like biting, oral sex, it's not going to rise to the level of being prosecuted in California any longer. In California's law now, they require transmission, and they include that same defense, that if you're compliant, for instance, with ART in the HIV context, that would be a viable defense to this crime. And again, I'm not going to go through all the details of these statutes, though I have provided them for your edification and hopefully for your reporting out. But ultimately what it comes down to is looking at behavior that is intentional, that is willful, and considering the science as it relates to providing defenses. I will also note that in California, a couple of other aspects were addressed that are important and helpful. The confidentiality in their cases extends to both the alleged victim and the person that's accused. You may be familiar here in Georgia, if there's someone, for instance, who's a victim of a sex crime, the media doesn't report their name. There are ways that we protect certain victims of crime. And in California, not only are they protecting the alleged victim, but they're also protecting the accused person. Because as we know, accusation does not mean guilt. And if we were to continue to allow a lack of confidentiality for those accused here, we're just still reinforcing some of those fears and barriers to care and to knowledge of status. And although California did decreased their penalties from felonies to misdemeanors, they have retained some HIV-related sentencing enhancements in the sexual assault context, which you might expect.
Okay.
And that is really the bulk of it.
That. Thank you for the presentation.
You're welcome.
Okay. Dr. Falzine.
Thank you, Madam Chair. Wonderful presentation, especially comparing this to other states.
Right.
But with some of the other states that have changed their laws so recently, do you have any information or has there been any in-depth evaluation of positive or negative outcomes of this reformation in Iowa and in California?
No, it's really too soon to tell
Too
on
soon,
both.
that's what I figured.
California's really, I mean, it really was, I think, last week that Governor Brown signed it. So, and with Iowa, with most, I don't know how true this is in the medical field, but a lot of our reporting in the criminal world kind of delays by a year or so because you just can't get that data in that quickly. But if some comes available, while you all are still meeting, I'll certainly forward it on.
Well, I would make a suggestion that if she goes forward, probably wouldn't mention California all that much.
Yeah, well,
It's probably not a good.
unfortunately, we aren't seeing much in the South yet, but as it begins, as we lead the way
Iowa's
here,
okay.
as we lead the
that's
way.
good. So, no, probably not a good thing. And if you will think there is a time for everything.
Certainly,
And next year's session's probably going to be really, really short.
yes, I understand.
And probably not the time to introduce any new legislation on certain things, so, but certainly to look forward and information to look forward, and you've been very helpful with the suggestions in the back, and I really appreciate.
Certainly, and we would certainly be
Those.
willing to help with any kind of drafting or proposals that you might desire this year, next,
Well, I
whenever
think
the time
might be
comes.
something to work on, since I think probably it's gonna be a very short, could even be a little contentious since several people are running for the same office, they're down in the legislature. Could be, I mean, I don't know, maybe a perfect session and just go through and have no interesting things at all.
Well, that wouldn't be any fun, would it?
But it doesn't usually happen when there's statewide races and several people running for office, so, thank you very much for the
Certainly.
presentation, and I appreciate everybody that's presented today. Like I say, the information that's been provided even to us to look at is even greater than what's been presented here. So October 30th is our next meeting, and I will look forward to seeing everybody. I think it's about 10 minutes to 12. We are adjourned from the meeting, and the committee members, we have a field trip that we're taking. So why don't, just to be perfectly blunt, take 10 minutes for a restroom break and then meet downstairs in the main entrance to the lobby, and let's get on the bus so we can be underway by no later than 5 after 12. So.